Táo bón mãn tính. Và sau đây xin trân trọng ban tổ chức xin trân trọng kính mời giáo sư tiến sĩ Ki Uk Chung từ Đại học USA Hàn Quốc có bài trình bày về táo bón mãn tính, định nghĩa, sinh lý bệnh và biểu hiện lâm sàng. Xin trân trọng mời giáo sư.
Thank you for this opportunity to speak in Asia Pacific University Foundation meeting. Today I will talk about chronic constipation, definition, pathophysiology, and clinical diagnosis. This is my disclosure. First, I would like to begin by discussing the definition of chronic constipation. In simple terms, constipation can be defined as unsatisfactory defecation resulting from infrequent stools, difficulty stool passage, or both. Symptoms include, though are not strictly restricted to, hard stools, excessive straining, infrequent bowel movement, bloating, and abdominal pain, and if such symptoms last more than 1 month, constipation is labeled as chronic constipation. This slide shows the long-form criteria for functional constipation IBS-C. In functional constipation, symptoms last for at least 6 months, and the patients have the 2 or more features such as straining, hard stools, and sense of incomplete evacuation without significant abdominal pain. In contrast, IBS-C is defined by recurrent abdominal pain at least once a week, related to defecation or change in stool frequency or form. So the case differences with the abdominal pain is essential for IBS-C, while it is absent in the functional constipation. Patients with the functional constipation usually do not have the significant abdominal pain. On the other hand, IBS-C patients typically experience constipation along with the abdominal pain. According to the long-form concept, these two conditions are thought to exist along a continuum rather than the distinct disorders. In general, IBS-C involves the stronger element of the visceral hypersensitivity compared to the functional constipation. Chronic idiopathic constipation, patients who meet at least 2 long-form criteria in more than 25% of the bowel movement without abdominal pain or bloating as the main symptom. IBS-C, on the other hand, also meets long-form criteria but includes abdominal pain as a predominant symptom, occurring at least 1 day per week in the past 3 months. It is important to note that both CIC and IBS-C usually have the hard stools. The patients with the rectal evacuation disorders have difficulty evacuating stool from the rectum due to physiological or structural abnormalities. This condition is sometimes referred to as the dyssynergic defecation or peripheral dyssynergia. On the other hand, slow transit constipation is characterized by the delayed colon transit and usually requires objective testing for diagnosis, such as cyst marker study, the wireless motility capsule, or scintigraphy. This slide shows the three major types of the primary constipation. The most common type is the normal transit constipation, which often overlaps with IBS-C. Slow transit constipation is characterized with reduced phasic colonic motor activity and occurs more frequently in women. Finally, patients with the pelvic floor dysfunction refers to impaired coordination between the pelvic floor muscles and the anal sphincter during defecation. This condition can overlap with both slow transit constipation and normal transit constipation. This slide shows the causes of the secondary constipation. A wide range of medication can cause the lead to constipation, including opioid, calcium blockers, tricyclic antidepressants, anticholinergics, and neuroleptics. In addition, metabolic and endocrine disorders can also contribute. For example, electrolyte imbalance such as hypercalcemia or hypokalemia, as well as hormonal changes like the hypothyroidism or pregnancy may result in constipation. Psychiatric disorders and the neuroleptic conditions such as Parkinson's disease and multiple sclerosis can all contribute to constipation by affecting the gun motility. Aging itself is also as an important factor, as well as the generalized muscle diseases like the progressive symptomatic systemic sclerosis and lordosis. Finally, organic diseases of the gastrointestinal tract, including colorectal cancer, should always be excluded. Next, I'd like to talk about the pathophysiology of the chronic constipation. In patients with slow transit constipation, abdominal colonic contractility has been well characterized. Compared with the healthy individuals, these patients showed a reduced number of high amplitude propagating contractions, which are the key propulsive motor patterns responsible for mass movement and defecation. Slow transit constipation is associated with abnormalities in the peristaltic circuit, resulting from the disturbances in enteric parasympathetic input or enteric neural control. In patients with severe slow transit constipation, pathological studies reduce the colon have shown loss of structural abnormalities of interstitial pH, which play a key role in the coordinating colonic motility. This figure shows the representative example of the real response in the descending and the sigmoid colon. The healthy subject is shown on the left side and the patient with slow transit constipation on the right side. As you can see, in the healthy subject, there is a rapid increase in the colonic motor activity immediately after the meal. However, this postprandial response is absent in the patient with slow transit constipation. Recently, our group published a study of the long-term prognosis of slow transit constipation. In the long-term follow-up of the patient with the constipation in Korea, most patients had no severe complication. However, patients with older than age 65 years with a new diagnosis of slow transit constipation might be considered for the Parkinson's disease screening. Defecative disorder, also known as the functional aortic obstruction, and erectile dysplasia or pelvic floor dysfunction, are caused by either reduced erectile propulsive force or increased resistance to evacuation. The increased resistance can result from the elevated resting pressure or condition known as the anismus, or from the paradoxical contractions and the incomplete relaxation of the pelvic floor and the external sphincter muscle, collectively referred as the dyssynergia. Defecatory disorders primarily develop due to inadequate pelvic floor contraction during the attempted defecation. In addition, other abnormalities can coexist, such as the induced rectal sensation or structural deformities like lactocele or excessive perineal descent. This condition may occur either as the primary causes of the constipation or secondary consequences of the chronic straining. As you can see, dysregulation defecation can occur through the several mechanisms. These include the discoordination of the pelvic floor muscle, paradoxical contraction of the anal sphincter, inadequate abdominopelvic propulsive force, and defecation. This slide shows the rectal pressure volume relationship during the biostep. Patients with rectal hyposensitivity have larger rectal capacity and higher compliance compared with those with normal sensation in the healthy subjects. Recent studies suggest that gut dysbiosis contribute to constipation. An imbalance in gut microbiota can show intestinal transit and impair function. Factors such as the poor diet, antibiotics, chronic diseases, and stress disrupt the gut flora, causing mucus depletion and increased permeability. These challenges can lead to immune activation, sensory nerve stimulation, and altered motility, ultimately promoting constipation and other GI disorders. In human, chronic constipation is linked to the alterations in the pulmonary mucosa microbiota. Notably, there is increased bacteroides, mainly due to the higher levels of lactobacterium. Even after adjusting for diet and transit, this common microbiome distinguished constipated patients from the control with the 94% accuracy, suggesting that microbiome signatures may serve as a biomarker for constipation. This slide illustrates the major often overlapping pathophysiological mechanisms of chronic constipation. Multiple factors contribute, including genetic predisposition, gut dysbiosis, defecative disorders, and colorectal dysmotility, impaired rectal sensation, and psychological influences. These mechanisms frequently interact, making pulmonary constipation a bacterial and heterogeneous disorder. Now let's move on to the clinical diagnosis of the chronic constipation. The stool form can provide an important clue in evaluating constipation. According to the Bristol Stool Form Scale, type 1 and 2 stools are commonly associated with slow transit constipation in patients with chronic constipation. Colonoscopy should be performed in patients with constipation who present with alarm symptoms, or in those who have not undergone appropriate colorectal screening. The red flag signs that warrant further evaluation include unintentional weight loss, anemia, rectal bleeding, a family history of colorectal cancer, distal onset of constipation, and changes to saliva. These findings should always raise suspicion for underlying organic diseases such as colorectal cancer or structural obstruction. This slide demonstrates the distal rectal exam finding resting in the paradoxical anal contraction. In the resting state, anal sphincter and tuberculous muscle remained normal tone. However, during attentive defecation, some patients showed the abnormal paradoxical contraction of the external anal sphincter and the tuberculous muscle instead of relaxation. As a result, the examiner's fingertip is displaced anteriorly, which is the characteristic finding suggesting dyslogic defecation. Okay, so our group compared the diagnostic accuracy of the distal rectal exam with the high-resolution energy manometry. As you can see, the distal rectal exam demonstrated high sensitivity and strong positive predictive value for detecting dyssynergia when compared with the manometric findings. Therefore, distal rectal exam can serve as a useful bedside screening tool for the diagnosis of dyssynergic defecation. Physiologic tests are indicated when patients don't respond to standard medical therapy, when the diagnosis is uncertain, or to differentiate the slow transit constipation from defecative disorders. There are several techniques available to measure pulmonary transit. The radiopaque marker study is a simple and practical method for assessing colonic motility. It is widely available, used to medical screening the patient with chronic constipation. It is easy to perform, reliable, inexpensive, and well tolerated by the patient. In this technique, the patient swallows one capsule containing 20 to 24 radiopaque markers once daily for 3 consecutive days, followed by the abdominal X-rays on day 4 and 7 to assess marker progression through the colon. This slide shows the results of the radiopaque marker study. In the normal pattern, fewer than 6 markers remain on the colon. In coronary inertia, markers are scattered throughout the entire colon, indicating slow transit. In contrast, in aortic obstruction, the markers accumulate in the rectosigmoid area, reflecting difficulty with evacuation. The scintigraphy method is not widely available, but it can be used to evaluate the colon transit. The smart pill system was to measure the intraluminal pH, pressure, and the temperature after ingestion of the single-use capsule. It provided a valuable information on GI transit and motility, but unfortunately, its production has been discontinued. Next is variant echography, a fluoroscopic test that evaluates both the structure and function of authentication. This image shows the regulatory angle at rest and during the straining. At rest, pubicalis muscle keeps the angle sharp to maintain continuous. During straining, the muscle relaxes, the pelvic floor descends, and the analytical angle widens, allowing passage. If this relaxation fails, it indicates dyssynergic defecation. The echography measures the several key parameters, the equilateral angle at rest and during the straining, anal diameter, degree of the rectal emptying, and pelvic floor descent. This finding helps evaluate both structural and functional causes of constipation. However, while the echography has some limitations, the technique is not fully standardized, and results can vary depending on the operator's experience. Also, a symptomatic subject may show finding in vegetative disorders. Now, let's move on to the analytical manometry, which is the key physiologic test for evaluating analytical function. The method of analytical manometry vary widely across the clinical centers. According to the international survey, there are several significant differences in how parameters such as resting and squeezing parameters, as well as the other measurements, are performed and interpreted among institutions. Therefore, the International Analytical Physiology Working Group developed a consensus called the London classification. This system was established to provide a standard protocol and uniform diagnostic framework for assessing analytical dysfunction. This table summarizes the specimen universe, and this slide shows the diagnostic framework. However, currently using London classification still depends on the conventional manometric parameters from linear pressure direct tracing rather than using new spatial temperometrics provided by the high-risk analytic manometry. So there is still room for improvement in how we characterize this dyssynergia. This study evaluated the prevalence of analytical phenotype based on the London classification in patients with chronic constipation, fecal incontinence, and overlapping symptoms. Disorders of the anal tone and contractility, as well as disordered rectal sensation, were common and varied among patients reporting fecal incontinence, chronic constipation, and overlapping symptoms. Moreover, the study confirmed that these abnormalities influence disease severity, with anal tone and contractility affecting the severity of fecal incontinence and rectal sensation contributing to the severity of chronic constipation. In contrast, most rectal anal coordination disorders appeared in similar proportion across the symptom groups, except when using the balloon spreading test. They were not related to constipation severity, and there was about a 50% mismatch between balloon spreading test and manometric findings. To address these limitations, we developed new parameters using the hydrogen energy manometry called IPB, similar to DCI and espargem manometry. IPB is the calculated from the pressure, amplitude, and spatial length and time during the simulated devication. In healthy volunteers, it showed a strong correlation with balloon explosion performance. In this follow-up study involving 200 constipation patients, a partially scaled regression model using the integrated pressurized volume showed a superior predictive accuracy of balloon explosion test. This recently published study, an AI-based model to predict the delayed balloon explosion using HRM data and with IPB. This slide shows the key results of our study in men and female with constipation. The AI model using time series IPB showed excellent accuracy in predicting balloon explosion. The balloon explosion test is a simple and physiologic way to assess the efficacy of balloon filled with 50 ml of water is inserted into rectum and the explosion time is measured. Healthy subject can usually expel it within the 60 seconds. However, even within London protocol, the type of balloon used for test has not been fully standardized, which can lead to variability between centers. Moreover, high-resolution energy manometry systems differ among manufacturers in particular design, diameter, and number of channels and pressure-sensitive technology. These differences may cause variability in measurement and interpretation between centers. This slide compares normal analytic pressure values from different studies. As you can see, the normal value vary widely depending on the catheter system, including its design, number of sensors, and manufacturers. This table from the recently published review article highlights the main challenges of the high-resolution analytic manometry. There are differences in catheter design and sensing technology among manufacturers, so data must be compared with technique-specific normal values. The nanoscale 3D probe is rigidly large, which can cause the artifact because it doesn't conform to the rectal angle. Moreover, normal values are limited, reducing diagnostic accuracy, and circumferential and pressure topography still requires further validation. This flowchart summarizes diagnostic approach for chronic constipation. First, evaluate the patient through the medical history and this rectal exam. If there is the alarm symptoms, or no prior colorectal cancer screening, proceed with the investigation for the organic disorder, including the colonoscopy. If not, manage as functional constipation with lifestyle modification and aseptics. When symptoms do not respond to treatment or when DRE suggests intensification, perform physical tests to identify underlying mechanisms. This flowchart shows the diverse approach for patients who do not respond to laxatives or strongly suspected of the hereditary disorder. The first step is to perform the energy manometry and the balloon explosion test. If both are normal, balloon transit time study to distinguish between the normal and slow transit constipation. If the manometry and balloon explosion test is abnormal, perform the echography to identify functional difficulty disorder or structural pelvic floor abnormality. Patients with functional disorders should receive biofeedback therapy, while the surgical therapy treatment can consider for the structural disorders. To summarize, the primary chronic constipation include overlapping subtypes such as the normal transit constipation, the vacation disorders, and slow transit constipation. The pathophysiology is multifactorial, involving colitis motility, evacuation disorder, altered visceral sensation, and gut microbiota imbalance. Physiologic tests, including colon transit study, echography, energy manometry, and balloon explosion tests, are essential to identify the underlying mechanisms. The London Protocol and classification provide the novel diagnostic framework, but they still require further validation with larger clinical data sets. Thank you for your attention.